Welcome back. Today it's Advanced MRI Physics Part 2. Again, I'm Dr. Matthew L. White. Here's our lecture outline for Advanced MRI Physics Part 2. As demonstrated in the prior lecture, we'll be continuing with looking at the echoplanar imaging technique. We'll start off with diffusion imaging, and this will cover the kind of basic diffusion weighted imaging and delve a little bit into the more complex diffusion tensor imaging. We'll look at the basic physics and the additional information that one can get with diffusion tensor imaging. The echoplanar imaging section will be finished by going over perfusion imaging. And then finally, we'll change gears a little bit and discuss spectroscopy imaging and look at its applications in neuroradiology. Okay, so here's a pulse sequence diagram for diffusion EPI imaging. Here we have all our echoes, as you might expect with the diffusion weighted imaging sequence. Probably would actually have 128 that we'd be obtaining with our sequence. And additionally, with the diffusion or diffusion tensor imaging sequences, there's a couple extra gradients added in here, and this gives us our diffusion weighting. They add some additional directionality to them that help encode differences of water motion within the brain in different directions. Here's a diagram. So if you're looking at diffusion imaging, the water might be moving slow or it might be moving really rapid. Maybe it'd be really slow when you're in an anatomical part of the brain that has a lot of white matter fibers, potentially like the corpus callosum. And you'll be moving faster when you're in an area of free water, like within the ventricles. So within the brain, the motion of the water is not so much isotropic. Now it is isotropic within the ventricles, but otherwise it's pretty much has anisotropic properties, is that it moves faster in one direction than in other directions. So if this is a fiber bundle of white matter from the brain, the diffusion will be slow for water molecules within the neuron when it's moving perpendicular to the long axis. When the water is moving parallel to the long axis, it'll move much faster. Just another diagram. So you can have free diffusion when the water molecule is in water or basically in the middle of the ventricle. When you add in cells, you start getting restricted diffusion. So if you have an area of a lot of cells, you'll have a lot less motion of the water, and we call that restricted diffusion. That also happens, particularly get restricted diffusion if you have cellular swelling, like with acute stroke, and you have cytotoxic edema. And throughout the brain, in many, many places, you have the restricted diffusion, the anisotropic diffusion, secondary to the different directions that the white matter tracks are heading. Here's a diagram showing the images that are obtained if you just do a diffusion weighted sequence. Basically, you get images of the brain with weighting of that diffusion gradient that I showed you in 3 different directions. You'll get one that goes craniocaudal, you'll get one that goes right to left, and you'll get an image with the diffusion directions anterior to posteriorly. Also, there's an initial image obtained, kind of a baseline image, that doesn't have any diffusion weighted gradients at all. That's your B0 image, and as you can tell, your B0 image is basically a T2 weighted image. And then these images are that same image with those diffusion gradients in the 3 different directions added. And you usually don't see those 3 different directional images. What you see, like in the PAC system, is this image where those 3 are combined. And they're combined because it makes for a much more homogeneous appearing image. It takes away the anisotropic appearance of the image due to the white matter fibers going in different directions. So for instance, in this image, the diffusion gradient, this is the one with the diffusion gradient craniocaudal, and this one really makes the splenium of the corpus callosum bright, because if you're going craniocaudal, the water in the splenium is moving really slow because it's not moving along the long axis of the white matter tract. But then if you move up to the posterior internal capsules, you see the posterior internal capsules are particularly dark in this scenario because the water's moving pretty much freely, or a lot more freely anyway, in the craniocaudal direction in the areas of the posterior internal capsule. And of course, the ventricles are very dark because the water's moving quite freely in any direction. So here's an image of the diffusion gradients there in the AP direction. And so the splenium of the corpus callosum, the appearance has changed a fair amount. It's still relatively bright centrally, but the little limbs coming off have gotten dark. Now this demonstrates two factors where you're going perpendicular to the main white matter fiber tracts here centrally, so the water's moving slow. And then here in the little limbs where they're kind of heading backwards, you're getting a more parallel appearance, parallel motion to the water, and it's moving faster, and so it's basically dephasing and getting darker. And with this AP gradient, the posterior internal capsule fibers are going more craniocaudal. So here where you're going AP, you can see they get bright because now you're applying the diffusion gradient in a direction where the water is moving perpendicular to the main white matter fiber tract. So diffusion weighted imaging, the water is always in motion because of the thermal energy, so it's always vibrating and moving, and so when it's in the ventricles, it's moving pretty freely around, and it varies in the other areas of the brain, predominantly in normal because of the different structures. Now the water moves a little bit differently in gray matter versus white matter, and of course the underlying white matter tracts really cause a profound effect on how the water moves in a particular direction in any specific area of the brain. And so it's this water motion and imaging it that helps us make this diffusion weighted image. You have 2D diffusion. Predominantly we're talking about kinetic molecular theory of the diffusion. It's the same mathematics basically as a Brownian motion, although Brownian motion actually describes a macroscopic type of motion, not microscopic. So the molecular motion, obviously the molecule in the water, in the ventricle, it'll be moving pretty freely in all three dimensions, and that water motion is isotropic. But since in the brain parenchyma, there's all kinds of things, vessels, but predominantly it's being affected by the white matter tracts and the directions of the fibers. And there's all kinds of different parts made up with that. And they are all affecting the motion of the water. So what this means is in diffusion weighted imaging, if molecules are experiencing a changing magnetic field, they're less likely to be rephased. And we have this special extra directional gradient applied, as I demonstrated earlier in the pulse sequence. Again, it might be craniocaudal, might be left to right, it might be some variation of those. So when you have an area of moving water, what happens is you have a decreased signal, and this particularly occurs in the brain in CSF, and also you'll see that in areas of vasogenic edema. Here's a diagram emphasizing the benefits of keeping molecules in phase when you're making an MRI image versus out of phase. So if you want to optimize your signal, it's good to have your molecules stay in phase, because then when you add their signals together, it's a constructive interference. It basically builds your signal. You have better signal to noise. If molecules are moving, it tends to cause dephasing, loss of signal, and then when you collect your image, you have a smaller waveform, you have less signal. Now with diffusion imaging, you're kind of smartly using this to create areas of lower signal that then you can potentially utilize to look at the white matter directionality and the underlying white matter integrity. So kind of a review here with the DWI sequence. With the DWI sequence, this triangle here is a direction of gradient. So truly you're like potentially making the left gradient stronger than the right. And so if you have an area where the water molecules are not moving, they remain in phase and you get stronger signal. But if it's along a neuron and it's moving pretty fast, that water is going to move over this gradient, and it's this gradient and this motion along this gradient that results in the water molecule creating a signal that is then out of phase. So in this scenario where the water is moving, you have a greater loss of signal. So if you did something or something occurred, such as an acute stroke, and then the water molecules aren't moving as much, you have an area of greater signal. And we use something with diffusion called apparent diffusion coefficient. This is used a lot, particularly analyzing for acute, subacute, or chronic strokes. So you have two images, bottom line and the end, that can be analyzed. You can do that off of 3 images, all 4 images. But basically, you have your B0, your T2 weighted image where you started, and this is your addition image where your X, Y, and Z direction has been added together. So it's a bit homogeneous looking. So you have your diffusion imaging. In this case, it was performed at B1000. That's how much diffusion weighting there is. And so if you want to see and calculate an apparent diffusion coefficient, basically there's an equation. You take the signal intensity like in this area and in the same area on your B1000 image, and then you make a calculation. It's actually fairly straightforward. The calculation for ADC is fairly straightforward. It's the negative natural logarithm of your second signal intensity over your first signal intensity divided by your B value. So basically you're looking at the slope of the line. It's pretty straight between B0 and B1000. It's not perfectly straight. And it's also, you'll have a little bit of difference of your ADC values, as you might guess, between different gray matter versus white matter structures. A little bit different. So when you're looking at a lesion on a diffusion imaging, early on, you'll learn about T2 shine through. So basically, this is B0 here, your baseline image, which is basically a T2 image. And here again, we have our lines of expected diffusion changes from your gray matter and your white matter as you go from B0 to B1000. But if you have a lesion and it has a lot of T2 signal, you're actually going to be starting with your B0 signal way up here. And so potentially you might be knocking away a lot of that signal. It might be really watery, might be very edematous. But yet when you come down and you look at your B1000 image and you make a measurement, you still might have more signal than the normal brain. And so you can't just look at that diffusion image. You need to look at the ADC image to see if that ADC value is really restricted, to see if the slope of the line is steep or shallow. So if you look at the ADC value on this line, this would be pretty high because you're losing the signal pretty quickly. But if you look at the diffusion image itself, it's going to be bright and might be sort of a fake out for an acute stroke. So that's basically called T2 shine through. Now, if you have a real acute early subacute stroke, the signal intensity on your B0 is going to be pretty similar to the brain parenchyma. Maybe it'll be just up a little bit, but also because in the acute subacute stroke, you have cytotoxic edema, the cells are going to be swollen, the signal will fall off much slower than in the adjacent normal parenchyma. And so that area will remain bright. And when you look at the ADC value, basically the natural log of the slope of the line, you'll have a lower value. So areas with lower ADC values are truly restricted. You'll have a lower value in your area of acute subacute stroke versus your areas of normal brain. And this might be an area of demyelination, which predominantly have elevated diffusion and lots of T2 signal. And a number of times, demyelinating lesions do have T2 shine through, but then on the ADC, they actually have elevated values, not restricted values. So that's why we care. And it's not just acute strokes, although that is by far what we're utilizing it for. Do a lot of work with diffusion looking for acute or early subacute strokes. There's a number of other potential applications. We look at diffuse axonal injury. In the acute scenario, those lesions have cytotoxic edema. This doesn't occur too much, fortunately, but infections or viral encephalitis, those areas can be highlighted because they'll be restricted due to cytotoxic edema. Also, somewhat differently, but it does result in a lot of increased signal and relative restricted diffusion compared to free water. In abscesses, you'll have a bright signal centrally because of the tenacious, thick material in the center of that, quote, cystic abscess. You'll also have areas of cytotoxic edema in recent seizure activity and a couple rare causes of restricted diffusion, CJD and Wernicke's encephalopathy. Of course, diffusion is very useful and has found a number of applications for looking at white matter tracks a little more specifically. Then you can see them on like regular T2 or T1 images. Also, hypercellularity in tumors can be evaluated with diffusion weighted imaging or diffusion tensor imaging. So a diagram, kind of a gross diagram, a simplistic diagram for acute stroke situation. This would be considered the normal. You have cells, let's consider these normal in size, and you have an extracellular space, and this is a normal amount of extracellular space. And then simplistically, although a lot more than this is occurring, in an acute or early subacute stroke, you have cytotoxic edema. Water collects within the cell, it can't pump it out, it swells, and the amount of extracellular space decreases. So you have water trapped within the cell. It's moving less, so it's dephasing less, so it remains bright, and you have less water out in the extracellular space that would be moving more freely. So you have less free moving water and more water that's trapped and moving less, and so that results in increased diffusion signal, and your ADC values will truly be restricted or decreased. Is this the whole story in acute stroke? Probably not. Probably not the whole story. In normal tissues, you have a lot of different things that can contribute to water motion, but that diagram is pretty nice for kind of solidifying and helping one think about the major process that is likely occurring in acute/subacute stroke. Again, the other causes of restricted diffusion. You have cells. If you have an area with a lot of cells, they could be inflammatory or neoplastic. Hemorrhages, they actually can and often do have restricted diffusion, or unusual scenarios, but it can happen if you have something that increases the amount of protein in an area, that can give you restricted diffusion. So again, just to review a little diagram where you have many cells, you have low extracellular space, and you have restricted diffusion. If you only have a few cells and a lot of extracellular space, the water can move quite freely, and so you will have higher diffusion, higher ADC value. There are many different tissues and lesions that'll end up that we image in neuroradiology. And here's a somewhat interesting paper that I had written where we looked at tumors in the skull base, paranasal sinuses. A number of kind of unique pathology had some areas of restricted diffusion, and one had higher ADC values. So we also found areas of restricted diffusion in a lesion that had some very thick, dense keratin. Tumors that had collagen showed low ADC values. And somewhat surprising, tumors with extensive debris or necrosis had ADC values that were decreased. Often, areas of necrosis have elevated ADC values, but if you have area of necrosis that has extensive cellular debris and or hemorrhage products, blood products, you can get restricted diffusion. And so then lesions with myxoid stroma, because that myxoid stroma quite watery, they actually had higher ADC values. In this patient, 65-year-old with 5 weeks of confusion, we have a brain MRI T1 with gadolinium and just the straight up diffusion imaging. You can see on the T1 image with contrast, there's this enhancement in the ependymal region with some areas extending within the brain, also a small focus in the right frontal lobe. On diffusion, we don't see that small right frontal lobe lesion, but we have a lot of signal in the splenium and ependymal region here. Then to evaluate the ADC values, these are ADC maps. You can see it's a little darker here. Not a whole lot darker, but a little darker, so it is actually mildly restricted. Now, maybe it's not as restricted because maybe you have some edema mixed in. So things looking at lesions can get complex. You know, do you have increased cells? Do you have edema? Do you have necrosis? Do you have hemorrhage? So a lot of processes are going on. But this one would be very mildly restricted in its diffusion characteristic. Here's a CT image of the same patient. You can see the lesion is mildly hyperdense in the splenium of the corpus callosum and in the ependymal region. Surrounding it, there's lower density, that is vasogenic edema. So you often have a little CT hyperdensity in areas of tumors that have hypercellularity. And as you might guess, this was lymphoma. So ADC mapping has been used more extensively and systematically to look at lesions. It did not help 100% to divide them into different classes, but interestingly, when you compared the ADC values to FDG PET, it had more of an overlap, greater correlation basically than looking at the contrast enhancement. So if you're looking at different grades of the lesions, you can see there's a difference here between these two type of lesions, but there's also a significant overlap between them. So, you know, if you have markedly elevated, it's probably not the GBM anyway, but many of the lesions have similar values. Okay, diffusion tensor imaging. Basically, it's DWI with a lot more directions, anywhere from 6 directions to maybe 128 directions or even more. Basically, you get these more diffusion directions in hope of better delineating the directionality and characteristics of the white matter tracks. That's typically the reason. So with DTI, you can then calculate where the water direction is going. You have direction and magnitude from this tensor. You need to be able to collect at least 6 directions of diffusion weighting to calculate this tensor, and likely with a single tensor model, you're going to have one direction where the water motion is faster, and then perpendicular to this, you'll have vectors describing a lesser degree of water motion. So a lot of areas in the brain, the ellipsoid is sort of football shaped because the white matter tract is going in a specific direction. If it's isotropic, like in the ventricle, you'd have a rounder diagram demonstrating the water motion. It's the same in all the directions. So your isotropic model would be more like basketball, and your anisotropic diffusion model for a pixel would be more like a football. Here are fractional anisotropy maps that are color encoded to direction. So fractional anisotropy basically tells you about the integrity, the directionality basically of areas of white matter. And in the brain, that then reflects on the simple color coding in the different white matter tracks. So here you have some optic tract coming back to the lateral geniculate, which then goes into the optic radiation. Here you're catching a little bit of the cingulum. A number of the white matter tracks overlap, like the inferior longitudinal fasciculus. going to the temporal lobe, and inferior frontal occipital fasciculus, obviously going between the occipital lobe and the frontal lobe. And here you have some of that inferior frontal occipital fasciculus and the uncinate fasciculus. The uncinate fasciculus going between the frontal lobe and the anterior temporal lobe. On a slightly different section, you see this really red and well demonstrated anterior commissure. So it's a little commissure that connects the brain up right to left in the lower aspect of the cerebral hemispheres. So this fractional anisotropy that tells you about the unidirectional organization in the brain. If it's all unidirectional, it's a 1. If there's no directionality, it would be a 0, such as free water in the ventricle. So that's called the fractional anisotropy, and it's calculated from the values of the different diffusion tensor directions and the average direction of the diffusion tensors. For DTI, you need at least 6 directions of water motion. In research scenarios, often much greater than 6 directions are utilized. In our clinical scenario, oftentimes we're collecting 15 directions. It's still an outstanding question of how many directions you need and how you should collect them, like which angles of 3D should you turn your diffusion tensor imaging gradients on to really optimize to best demonstrate the connectivity of the white matter within the brain. You may need 20 to 30. Again, some researchers are obtaining many more, maybe 64, maybe even 128. Might use some different B values. You might use B0 for your basic map, then a B1000, maybe a B2000, maybe even. So sort of skipping ahead, and then we'll go back and explain it. If you take your diffusion tensor imaging data and the software using the fractional anisotropy, the directionality of the water, and looking at the angle difference between the main vector in each little pixel, you can create these white matter tract maps. This would be using a single tensor technique. And this is the cortical spinal tract, and the patient has a lesion. This image is flipped. This is actually over on the right side. So they have this lesion. Some of you might sort of recognize it. It has this T2B0 recon image. It has a dark outline and a bright center. The patient was having weakness in their left hand, and the tracts, we're hoping to see that they were displaced by the lesion, but the white matter tracts were running through the lesion, and you can see that that cortical spinal tract on the right side is attenuated versus on the left side. So, surgical resection was not attempted since this lesion is infiltrating the white matter tracts, not just displacing them. Even if it's displacing them, resection would be risky since the tracts would be right up adjacent to this lesion, which presumptively is a cavernous malformation, a benign lesion, but they can continue to hemorrhage and cause problems with the adjacent white matter function. So here's a little magnified view. I like this. This is from the GE software, which we no longer have a GE scanner, but here's a B0 image, our basic T2 image, and then you could draw a little circle, and then it would show you the pixel by pixel demonstration of the magnitude and direction of what the water motion was, and that would be reflective of the underlying white matter tract. So if you're making a tract here, going from the lateral geniculate into the optic radiation, you get a number of fibers twisting back to the occipital lobe. You get some fibers going up more anteriorly into the temporal lobe, forming Meyer's loop before they turn and then head back to the occipital lobe. So again, basically you're making these white matter tracts. This would be a demonstration sort of an arcuate fasciculus going from the frontal lobe down into the temporal lobe, and the software would follow from voxel to voxel. The directionality And if they're not turning too much, it would then connect them up. So you put in a parameter, look at everything that's similar to within 45 degrees or something like that, maybe 20 degrees. You can vary it and see the differences of your white matter tracks. It gets kind of complex, as you might guess. In any given voxel, there's white matter tracks going in all different directions. We're typically dealing with a 2 by 2 by 2 voxel. Neurons obviously are much smaller than that. And the white matter tracks going through a voxel, they could be parallel. And basically, particularly with single tensor techniques, which are basically what's utilized clinically, they're treated as everything sort of moving in one direction, but they can be parallel, they could be fanning out, they can be crossing. I mean, they might be crossing in all directions, all different directions, and not even only in 2 dimensions, but obviously in 3 dimensions. Fibers could be coming in and going out, or maybe they're just taking a turn in that voxel as they go down from, let's say, the parietal lobe down into the temporal lobe with the arcuate fasciculus. So there's a lot of different mathematical models that can be used and applied to this, and depending upon the mathematical model, as you might guess, you can get different sort of tractography appearances. So it's really almost, in a lot of ways, an art versus a science. Unfortunately, actually, white matter dissections on anatomical specimens are very difficult and have been described more in art than science. So there's a number of attempted solutions and ways to do things better. You can get these more complex diffusion tensor imaging techniques, basically more sampling, and then feed that into a software that has a little bit more complex analysis. And by doing that, you may get a better representation of what the underlying white matter tracks are. For instance, if you just use single tensor technique, which is pretty much what we have available to use clinically. It's the only ones that I know of that are FDA approved. And then if you use a multi-tensor technique, it's still not really thick as you might guess. I mean, there'd be just thousands of little fibers out here that it doesn't demonstrate, but you do see a number of fibers going out more laterally rather than just these central main fibers with the single tensor technique. All right, we're done with the diffusion, and now we'll talk about MRI perfusion. First published on this in 1990, so it's been around for a while. Wasn't applied clinically at that time. It wasn't readily available. The gradients, the EPI gradients that were needed were rather expensive and not probably clinically available even. So this was on a research scanner. They're looking at injecting contrast agent, and they imaged a dog's brain. And the contrast agent makes the signal drop out. So you're injecting an agent, and as we do today, we inject a gadolinium-based agent, and we're not looking at a T1 effect, but we're looking at a T2 star effect. We're looking at a darkening effect as the bolus passes through. So when the bolus passes through, you can measure the signal intensity on each sequence. It changes differently in the gray matter than the white matter, and this actually would be the physiological appearance that you would expect. You'd expect the gray matter to have a greater perfusion than the white matter. And hopefully that change of signal ends up representing the change of contrast, and it does seem to be the case. So our change of signal, this R2 T2 star effect, correlates to the changing actual contrast, which then from that you can calculate cerebral blood volume, cerebral blood flow. Of course, the full equation gets rather complex. Use a mono exponential decay. You can figure in the TE. Here's your negative natural log of the signal intensities. But bottom line, it does appear that holds more or less, that your changing signal intensity correlates to the actual changing concentration of the tracer of the contrast agent that you have injected. So then if you flip that curve for analysis, the contrast signal is going up And then that's if you approximate it. You have some problems here. You get some recirculation problems likely coming in and contributing to not having a perfectly optimal curve for the perfusion analysis. So if you look at your cerebral blood volume versus different PCO2s and make these measurements from your MRI imaging using your perfusion sequence, you see the expected physiological change. Basically, you see the expected increasing flow with increasing PCO2. So that's what you'd expect physiologically. Seems to suggest that using the perfusion technique will give you a measurement of expected physiological substance. So in general, your cerebral blood volume divided by MTT is going to equal your flow rate. MTT, mean transit time, so basically it's your volume divided by time, will give you flow, which is volume over time. So CBF equals CBV divided by MTT. And that's an example of a really nice perfusion curve. Our real perfusion curves typically don't look that sharp, unfortunately. So our perfusion seems to be really pretty simple. There are some particularly major problems. One, a little bit of a problem is that contrast recirculation that can occur while you're collecting your perfusion data. Another one is contrast leakage. The mathematical equations are based upon the assumption that there is no leakage of contrast. So a lot of times, though, we're doing perfusion on things that enhance. And if something enhances, that basically means you're having leaking contrast. That enhancement is due to breakdown of the blood-brain barrier. So that can affect our perfusion results. Usually it's just a little bit, but sometimes it can have a marked effect. So looking at your perfusion curve can be useful to tell if you're having contrast leakage or not, and to see how that's affecting your perfusion curve. Also, we get bolus dispersion. It's not a perfect little bolus of a contrast moving through a lesion, since we're usually injecting the contrast in the antecubital vein. So the contrast has to flow in, go through the lungs, go through the heart, and then it goes up to the brain. So that causes a dispersion of the contrast bolus, and isn't all that close to a perfect little blip of a contrast moving through the brain in the specific time. So the contrast recirculation is a problem. You see this little second smaller peak that through mathematical assumption is kind of usually removed. Again, contrast leakage. This is what I see as probably one of the bigger problems. The lesions we're looking at often have blood-brain barrier disruption. Could be a potential MS lesion. You know, those. It's an enhancing one. It has blood-brain barrier disruption too. You can use some things to avoid this. We do the lower flip angle techniques. Avoids this T1 contamination. So when the contrast starts leaking out, instead of giving dark signal, it basically starts giving T1 signal, and so you don't see as much of a loss of signal. But what will happen is it'll be coming through, and then you'll get this leak. You'll get this rising signal. Of course, then you don't know exactly what the true perfusion curve is. I mean, it'll make an assumption, probably take it like this, but you're still not capturing what the true amount of perfusion. It has been found, kind of interestingly, if you give some contrast first, so basically we split the dose, we preload with half the contrast, and that causes the contrast to leak out in the brain. And then when you give your second half and do your actual perfusion sequence, it doesn't demonstrate as much leakage. It actually markedly improves your view of the true perfusion extending through this lesion. Here are example images from a case that has marked contrast leakage. Here's their baseline image, and the lesion would be right in here. So if it has intact blood-brain barrier and high perfusion, the contrast would come in and cause loss of signal. Here we have rather markedly increased signal because the contrast is leaking out. So in this case, the contrast is flowing, and then instead of going down, it's leaking out and it goes up. And normally if it's a lesion with high perfusion, you should see a nice big drop in the perfusion of the lesion. So we processed out those source data, and over here on the right, we got our cerebral blood volume images, and then on the left, we have mappings of the contrast going through different areas of the brain. The green area is where that lesion was at, and you can see on the cerebral blood volume map, there's basically zero blood volume in that area. And in the normal area, you have a nice baseline, a really sharp, nice bolus, and then we have our baseline after the bolus has gone through. In the lesion, you can see quite a bit different appearance. You have our baseline here, and instead of having a dropout as we would expect, we have leakage. We have signal going up rather rapidly. With that rapid increase, that makes me concerned that we're more seeing leakage rather than maybe some slow oozing of contrast out if it was just necrosis, because if it's necrosis from treatment, I should have had a lot of dead tissue and low vascularity throughout this area. So in analyzing lesions, we often use a couple techniques to help us make sure we give as good an answer as possible. So usually if you're specifically very directly looking at a lesion, then we'll also do a spectroscopy. And on the spectroscopy, we get a completely different answer, and we'll talk a bit about this more. But basically, our choline NAA, you can see this red hot area. The choline is area about cellularity, and NAA is a normal neuronal marker. So you have very high choline or high cellularity and decreased normal neuronal marker, have a little bit of lactate here. So this seems to indicate there's a lot of presence of tumor here. If it was all necrosis, should have just a flat, jaggedy line looking like a necrosis. Maybe a bigger peak where there's a lipid lactate peak, could have a little bigger peak down in that area. But this raises concern quite strongly for representing recurrent GBM, and that was proven at surgery. So with bolus dispersion, using the central volume theory to calculate these values, you can calculate, if you get one of them, two of them, you can calculate the next one. You can get the CVV, MTT, and then use that to calculate your CBF. So CBV equals CBF times your MTT. Okay, so you get your CBV by looking at that area under the curve. And these are relative measures. You can make them a little less relative by using an arterial input function. Often, to help sort of normalize the data, you use a ratio. You take the ratio of your value within the lesion of interest versus some normal tissue on the other side of the brain. And that ratio helps to kind of correct for all kinds of different errors that can occur, be it different contrast, different magnet strengths, different boluses going through the body. It does help to sort of normalize the data, not perfectly certainly. So here's another example in a patient who has a lesion near Brocas area in the left frontal lobe. The cerebral blood volume map is over here on the right, and this is the source data on the left. And then up at the top, you have your curve data of the contrast coming through. And you can see we got nice baselines before and after the curve. It's kind of a spread out curve. You can see our cerebral blood volume in the lesion is pretty bright here, so a lot of perfusion versus these other areas of normal brain. Looking at our conventional maps, we have our T2 flare. See a lesion here, kind of iso-intense, heterogeneous T1, kind of iso to hypo-intense, again heterogeneous. Contrast enhancement, kind of thick rind of a contrast enhancement, fairly sharply marginated. Basically, you'd be thinking this might be a metastatic lesion, glioblastoma, a little thick rim, too thick of a rim for an abscess, could be a very unusual abscess, probably not. Here you can see it in the sagittal plane, basically the same imaging characteristics. So on the T2 flare here on this image, on the right, you have the lesion, and you have a lot of high signal vasogenic edema. So the vasogenic edema around it would definitely be elevated ADC values. Lesion itself could be elevated or restricted, so in areas of hypercellularity and maybe hemorrhage, you'd have more restricted diffusion. And so this is really in the language area, Broca's area, right smack in the middle of it. You can see the lesion on ADC did have restricted diffusion, probably likely related to hypercellularity, and the edema around the lesion was elevated, had elevated ADC values. So this is metastatic adenocarcinoma, is pushing language away from the lesion, and so pretty surprisingly, but excellent, they were able to remove the lesion and the patient had no language deficit after surgery. All right, that brings us to the end of our review of EPI techniques. Also, arterial spin labeling, this is a technique utilized for looking at perfusion. Has some advantage, has some disadvantage. It's gotten a lot more easily applicable over time. So with arterial spin labeling, basically you're magnetically tagging tissue, and basically what we're interested in is the blood that's magnetically tagged, and then it flows up and you look at in the brain a little time later, and you have a difference of your signal that you see from your control time to your flow time, and that is basically found out to be equivalent to CBF. This is without contrast, no injected contrast anyway. The contrast is the magnetically tagged blood flowing into the area that increases the signal. The good news is you don't suffer from gadolinium leakage, so it more likely will give you a true look at what the cerebral blood flow is. The problem is, as you might guess, since you're just magnetically labeling something, it's relatively low signal, so you have to do a lot of repetitive acquisitions to improve your signal. This is markedly improved over time. There's been techniques developed where you can label and sample, and the sequence itself for imaging almost all of the brain takes about 5 minutes rather than 15 to 20 minutes that it did a number of years ago. So it's gotten a lot faster, still a fair amount of time commitment, taking 5 minutes versus our gadolinium perfusion. You might only be spending 2 minutes, but yeah, it is a strong. So if there's a question of gadolinium leakage, there's a strong argument to run this technique on the patient. Warning, do not run ASL after gadolinium administration. If you already have given them gadolinium, you cannot then magnetically label the blood. So arterial spin labeling doesn't work after the patient has gotten gadolinium. You need to let all that gadolinium then clear out of the patient before you can run successfully arterial spin labeling MRI. So here's a 60-year-old female, history of endometrial cancer, has had multiple resections. Unfortunately, they have a growing mass. It's in their parietal lobe, kind of a mixture, heterogeneous appearance. This looks like vasogenic edema here. Gradient echo has some hypointensity, so probably some blood products. Diffusion, nothing really restricted. And the ISO, certainly not elevated, not quite as dark for the most part as the surrounding vasogenic edema. To really analyze that, you'd want to look at the ADC maps. Contrast, now this is kind of concerning. There's necrosis, would expect to see more irregular enhancement. This is pretty solid looking enhancement, so right away, pretty high concern that it's solid recurrent tumor. Perfusion maps, you can see there's high blood flow. So again, necrosis would be dark. This is very hot, so you have high perfusion. So very good for demonstrating tumor. If you look at spectroscopy, you also have moderate tumor spectrum. Actually, the perfusion performed better here. Maybe the spectrum didn't because you have a lot of things maybe possibly degrading your spectral quality. You're right up against the calvarium, so you're at the brain soft tissue interface. Spectroscopy is very sensitive to interface differences, but in general, your spectrum in the lesion does have an elevated choline. Your NAA is basically 0, and you do have a little lipid lactate peak. Now your choline is relatively elevated. You'd really like to see it maybe a giant peak bigger than your normal brain. So this one is from here. This spectrum is from here. You can see as you march from normal brain into the lesion, your choline is being relatively maintained. So it's being maintained. The other peaks are going down faster. So you have relative maintenance of the choline peak, not really elevated or a growing peak, but relatively elevated, and then you have more lipid lactate as you get into the lesion. So anyway, a number of times you do see this kind of relative maintenance of the choline peak, and that's pretty worrisome for representing an area with high cellularity, high cellular turnover. So this is an example of magnetic resonance spectroscopy. You look at specific voxels, basically a little less high res than a normal MRI. Probably should look at something at 3T, probably 1 centimeter by 1 centimeter. That's often a little bit to the small side, just depends on how much tissue versus solid tissue versus necrosis is in the voxel. You love it if you can have a 2 centimeter by 2 centimeter area size lesion. So if you're imaging, you're often looking at maybe 1 millimeter by 1 millimeter. Here we're talking 2 centimeter by 2 centimeter, maybe a centimeter by a centimeter. That spectrum at a centimeter by a centimeter may or may not work out. It may not have enough signal. So we do single voxel, can do a multi-voxel spectroscopy. The problem with spectroscopy is all those little peaks I was showing you. The main peak, the biggest peak by far, is the water peak. It is a gigantic peak within the brain. These other little peaks are just tiny little peaks kind of on the side of the water peak. So you have to suppress that water signal out before you can really see these other peaks. Predominantly for a single voxel, we're using point resolved spectroscopic pulse sequence, the PRESS sequence. There are some new, quote, laser techniques which are a little bit more accurate. Some of the problem, like with our typical spectroscopy, and even a greater problem when you're using multivoxel, is that the data kind of isn't as accurate to that voxel as you might expect. There's some kind of bleeding of data between the different voxels, and this newer technique, quote, laser technique, does make it a little more accurate. So here's your normal spectrum. You'll have a peak going up. In normal brain, you have some giant NAA, creatine, choline, myeloinositol, another creatine peak, and then here you have glutamate. Over here would be your lipid lactate. Fortunately, the frequency scale is basically the same at 1.5 Tesla and at 3 Tesla. So NAA, normal neuronal marker, also see it present in oligodendrocytes. So here's your biggest peak in normal brain. NAA. Unfortunately, it is decreased in many diseases. Anything that sort of destroys brain have decreased NAA. So a lot of these peaks, somewhat specific, but also kind of non-specific. So that's kind of an argument against spectroscopy, is a lot of disease processes have very similar spectrums. So creatine, phosphocreatine, main peak 3, secondary peak at 3.9, kind of used as an internal reference, but it's really not that stable. It changes in pathological entities. Still kind of use it as a stable reference peak, but we use it knowing that it's actually not that stable. Choline, have usually kind of a moderate sized choline peak at 3.2 right here, right next to the creatine. You'll see it a little bit different in gray matter and white matter. Used basically to give a judgment of cell membrane turnover. See it elevated in tumors. Also, it elevates in demyelination. So it can be very, very difficult to tell the difference with spectroscopy between a enhancing tumefactive demyelinating plaque and some other tumor. Those spectrums are very similar. If you do enough and you compare it in a pool, the demyelinating lesions don't usually have as elevated choline, but that's often kind of a soft call, hard call to make in any individual case. Also, you got other etiologies where you might have some elevated choline. Myoinositol, we don't see it too much. Can see a little bit elevation in the low-grade astrocytomas, although I've never been able to use that clinically. You also see your lactate peak at 1.3. In low-grade oligodendrogliomas, might see some elevation of the glutamate peaks right here between 2.2 and 2.6. So we often look at these spectrums and maps, or just at numeric ratios, and this is the area under the curve, not just the height, but actually the whole volume under the curve, the area under the curve. So using our typical single voxel spectroscopy, when we see choline creatinine over 1 or NAA choline less than 1, makes us start thinking about brain tumor if it's the correct scenario. Here's a spectroscopy that has a markedly elevated choline peak. The NAA peak for normal neuronal marker is really low, and the creatine, that's also low. We treat that as internal stable peak of reference, but as I said before, it often decreases in numerous pathologies. And in this case, we have a little bit of a lactate peak. This was performed, you can't quite see that there, with a TE of 35. So that's actually a short TE spectroscopy. If you perform the spectroscopy at a certain TE, such as TE of 144, then you can invert the lactate, make it go upside down, and that can be some more proof that that's truly a lactate. Okay, so here we have an angle going down. So that's Hunter's angle. Before I talked about the angle going up, and that's good. And when you have the angle going down, that's bad, but this angle analysis can be thrown off because sometimes you have a really large lactate, lipid, and lactate peak, and then if you take arrow, it really goes like that. But you kind of have to ignore the lipid lactate peak and just draw it down like that in those cases. Anyway, that's Hunter's angle. Good is going up, bad is going down. Here we have an example of chemical shift spectroscopy or multivoxel spectroscopy, kind of pushing the resolution here. We did get a great signal in this case, and this overall, what we're looking at is a color-coded choline creatinine map. So where it's redder, you got higher values versus lower values. So the main concern would be MET or glioblastoma. Less likely to be an abscess given the thick rind. Some abscesses do have thick rinds, and so then you can actually look at the ratio numbers here as you go from within the lesion to outside of the lesion, And so you have this, tumor signature, elevated choline creatinine in the lesion, and also outside. This is hanging out a fair amount above 1. When you get down near 1, that's going to be sort of more normal. Maybe a little above 1 would be normal too. You can also get the choline NAA ratio. Here we are above 2. And again, when you get down above 1, near 1, you're going to be more of a normal area. So going from markedly abnormal to nearly normal with a metastatic lesion wouldn't have the extension outside of the area of enhancement. So you have this very tumoral signature in this location that argues for a primary tumor over a metastatic lesion. Okay, an overview of the metabolic abnormalities in spectroscopy. Good thing is, in general, this is kind of easy. For many etiologies, you have increased choline and decreased NAA. Okay, you're done. You can go home. You'll see this in many different pathologies. As I mentioned, glial tumors, metastatic disease, you can see that, multiple sclerosis. So spectroscopy doesn't help you that much in telling a tumor fact of multiple sclerosis from some neoplastic lesion. There's papers looking at groups of lesions, and they do find that the MS spectrums are statistically different than neoplastic lesions, but it can be very difficult to make that discernment in any single case. So even HIV, Alzheimer's disease, chronic hypoxia, and diabetes have this abnormality. Of course, you look at the rest of the image, and Alzheimer's disease is going to look quite a bit different than metastatic disease or a case of multiple sclerosis. Meningiomas have some interesting peaks, alanine and aspartate. Someday I might find this useful. I haven't found it useful yet, unfortunately. We hardly ever do a spectroscopy of something that we consider a meningioma, and when done, it's usually just because you want to test it to see if you can find a alanine and aspartate, so it doesn't really come up. Abscesses. Now, abscesses have a lot of potentially interesting peaks. Usually from their other imaging characteristics, you can tell it's an abscess. They don't have to run a spectroscopy to further analyze it. Also, here is a key is when you're doing an abscess or suspected abscess, you need to look at the abscess cavity, the fluid-filled cavity. Actually, you want to center your spectroscopy on the fluid-filled abscess cavity. On all these other lesions, when you're doing spectroscopy, what you really want to do is you want to do the spectroscopy of something solid where the actual brain tissue is, not of the cavity. The cavity just basically almost gives you a flat line, nothing. You might see a little lactate or something in it, but usually nothing. But in the abscess, you want to do the abscess cavity to see these potential interesting peaks. And I just throw in radiation necrosis because in the right situation, this is actually what we're often looking for. Radiation necrosis should be pretty much a flat line or a little jaggedy line. You might see some lipid and lactate in it, but in general, radiation necrosis is going to result in decreased peaks. So perform spectroscopy of the solid portion of the lesion, except for an expected abscess. So here's an example. 65-year-old male had a left temporal resection, anaplastic oligodendroglioma. Surgery was 11-2, then had 6 weeks of XRT, have a new area of enhancement in the left corona radiata, so in the more cranial portion of the brain. Here's a lesion, looks kind of solid, so that's kind of worrisome. And we did a multivoxel spectroscopy, choline creatinine, and we did it here to avoid the calvarium. So don't run your spectroscopy in the calvarium, and also try to avoid the ventricles if you can. Probably best, we'll get a better spectroscopy if you avoid the ventricles. So here we're looking at a choline creatinine ratio, and you can see within the lesion, you have this is very elevated, and also you have some elevation in the white matter, so you have this really infiltrating change in this case. Now this case is kind of interesting. You have this diffuse, quite a bit different appearance, kind of diffuse, infiltrating the more you look. Kind of see it here, maybe a little bit over here. See that here, a little T2 change even going into the posterior internal capsule. Have some mass effect. Septum is ever so slightly shifted to the left, even down in the cerebellar hemisphere, in the middle cerebellar peduncles, have a little T2 signal change. See the same thing on T2, kind of this infiltrating T2, but there's some mass effect, and the septum is shifted very slightly. This looks rather full. This is to say there is no contrast enhancement. So no matter where you looked, there was no contrast enhancement within the abnormality. Here we have two single voxel spectroscopies from this case. On the right is the spectrum from the left hemisphere, and on the left is the spectrum from the right hemisphere. And looking at the one on the left, it looks very normal, has that Hunter's angle going up, markedly elevated, or normal height, should say, NAA. Creatine and choline down here, usually the choline is a little less than the creatine, but sometimes it's slightly elevated. Then you look on the right hemisphere and still have an NAA peak, pretty well declares itself. But if you look, this is only at 1.5, and you look over here to the one from the left hemisphere, it's all the way up to about 2.5. So it's relatively decreased, and this choline is relatively increased, not quite, just near 1.5, whereas look over to this other one in the left hemisphere, it's right at around 1, just above 1. So the choline is a little bit up relatively, the NAA is down, probably have a little maybe lipid lactate in this location. So this would go with neoplasm, and this is what you might see with an infiltrating neoplasm. So in your spectrum, in that brain, you're getting some normal tissue and also some tumor. So you kind of get a mixed spectroscopy, and at biopsy, they found abnormality consistent with gliomatosis. All right, that brings us to the end of our lecture. Thank you very much for your attention.